Thank you so much for inviting me, Dr. Gupta and Dr. Palajani. Congratulations for putting together this outstanding meeting. Dr. Palajani, I am glad I made it here this year. 2 years before you had invited me and circumstances did not permit at that time. I know of the Academy's outstanding work, and I congratulate you for all you have done. You have also been a mentor, a wonderful teacher, and from many of us who have learned from you, my deepest gratitude. I will prove to you also, Dr. Palajani, correct about saving lives, and hopefully the next 30 minutes will do exactly that. This is my intent of the lecture, and I quote, "In the next 30 minutes, I would like to share my very unusual personal journey in STEMI interventions and review with you with sincerity and humility most of the lessons I have learned about STEMI interventions." This is the amazing work which was published in the New England Journal about 5 years ago from the Yale group of investigators who had made some amazing observations. And they came out with various strategies how you could perform primary PCI in an expedited fashion in a mandated manner which has now come to be known as door-to-balloon interventions. And not only just around the time when most of us were trying to figure out what exactly is a door-to-balloon time, they had even figured out how to reduce it. And they even quantified it. 5 minutes here, 6 minutes here, 8 minutes there, 10 minutes there. And they made these 6 recommendations, which I think are outstanding. However, I could actually stop my topic here and tell you, go read about it, you'll become an expert. On the other hand, if you see on the right, that's the trenches. I picked up a picture from World War. I sincerely and truly believe I have been living in these trenches, and hopefully a combination of what the investigators from Yale taught us and some of my own work living night after night doing these STEMI interventions will give you some useful take-home messages. So what can primary PCI STEMI intervention do in 2011? Maybe that's not the right question. I appeal to you, I appeal to your conscience, and I ask you, what is 30 minutes of your time worth today? 30 minutes of an interventional cardiologist, what can he do? Let's show you. So this is a patient, he was done on October 11, 2008. It was fortunately 3 in the afternoon. I subject to you that a STEMI intervention at 3 in the afternoon and 3 in the night is a totally different ballgame. But this is unusual. He's having a massive acute inferior wall myocardial infarction. He was having ongoing CPR. He had been resuscitated 4 times, and they were just about calling him off. I looked at the EKG, 52-year-old acute MI. That's the first lesson for you. There is no way these patients should die. The EKG on the right is taken about 18 minutes later. We took him to the cath lab, and I'd like to show you what we found. So this is the entire case with ongoing CPR. This is the picture of his left coronary artery. Here comes the left coronary artery angiogram. And if you notice there, what is happening is that you're able to see this is the compressions of the myocardium, which is forcing some blood into the left coronary artery. But you quickly see that the left coronary artery is normal, which is not different because the EKG is showing you the infarction in the right coronary artery. And this is, of course, the culprit lesion. Massive, looks like a large right coronary artery occluded with thrombus in its proximal portion. So what do you do quickly in most of interventional cardiologists? Within a minute, if not seconds, you put in a guiding catheter, you cross the lesion with the wire, and you put in a balloon, hoping this would be your lucky day and that the vessel would somehow magically open with one of these balloon catheters. And for a STEMI lesion, the balloon does exactly in this case which a balloon is supposed to be doing, which is basically nothing. So there is another lesson for you. Don't waste your time in a STEMI intervention with balloon angioplasty. This is the result with the balloon, does nothing. So at this time, you quickly pull out one of the aspiration catheters. And here comes there's a little challenge always in showing these angiograms. This is the aspiration catheter, which of course also does nothing. So continue CPR. At this point, I quickly opened one of these mechanical devices, which is the angiojet catheter. This is a mechanical thrombectomy. And this is this angiojet catheter here. Make several passes with that. And I'll quickly go on to, after about 3 or 4 quick passes, again, this is about 3 minutes into the case. This is what you've been able to recannulate the artery with mechanical thrombectomy. This is a placement of a 4.5 bare metal stent. And here is the result about 6 minutes after this man had been put onto the table. And that's his right coronary artery, completely recanalized. And you wonder and you observe that here was a man who was being pronounced and his artery has been opened and his life has been saved. That, of course, is a known miracle. What I think a lot of us appreciate less is not only do you save the life, but this is what you also do. This is his left ventricular function done immediately and almost normal LV function. So based on this case, I have made the following observations. This is my sincere database. It has dozens of similar cases. It's the beauty of such amazing results which keeps me going night after night. And I propose this to you to think it over. What other medical procedures do you know, except probably childbirth, which saves lives like this in such a dramatic fashion? And this is a very personal observation. Primary PCI saves the patient's life. In addition, it may even bless your own. Just a quick 2-minute review. What exactly are we able to do? How does lytic therapy compare with PCI? And what are door to balloon times? When you compare PCI with lytic therapy, there is really no comparison. It wins hands down. When you also compare that a patient is going to be transferred, once again you realize that so far as a transfer is concerned, and comparing it with primary PCI, even there primary PCI will win quite handily. What's the importance of early revascularization? This is a myocardium infarcting on the right hand side. There is a very critical early phase when you are able to salvage the myocardium. As you go down steeper, you are able to salvage less and less, providing you a rationale to work fast. And this is what created the door to balloon times. And if you realize here, this is what is happening. When I started doing STEMI interventions, our door to balloon time used to be somewhere around here with a mortality of 13.3%. That is down today something around here with a mortality of about 1.2%, with the door to balloon time in the last 8 years having gone down from 231 minutes to 54 minutes. What does it relate to? Now you've had a reduction of going and reducing the door to balloon time. What Dr. Palajani showed you, the care of myocardial infarction, if you look at it, just about everything we have done till today compares nothing to just doing a STEMI intervention with a short door to balloon time. So if you're able to reduce the door to balloon time, I think in most hospitals in India, it's going to be somewhere in this range. If you're able to bring it down here, you make more impressive reductions than every pharmacological agent known in mankind. Now everybody talks about door to balloon time. I think there are some other important lessons. I truly believe that achieving a door to balloon time is simply not enough. In fact, an overemphasis on door to balloon time can have some unintended consequences. We'll talk about that in detail. It is more important also to educate the patient. It is probably more important also to look at the overall ischemic time. If a patient has been having chest pain for 6 to 8 hours, and suddenly when he calls and then you start rushing and everybody is driving, killing themselves, I don't think it provides the rationale. The patient's ischemic time starts from the moment he has chest pain, and there is need to educate. I think it is also important to achieve an excellent acute angiographic result than just trying to chase a door to balloon time, and we'll share with you some of the lessons. Specifically, we'll talk about thrombus management and paying attention to myocardial perfusion grade, and also trying to take care of these things. It's not just enough to have ST segment resolution. I think having complete relief of chest pain, achieving a TIMI grade 3 flow, and myocardial perfusion grade are also important. This is the myocardial perfusion rate. If you take a look at it, these are the 4 examples. There is a grade which is grade 0 on the right, in which there is no blush, to grade 3 on the left, where you have a normal ground glass appearance. Basically, you're looking at how quickly the radio contrast agent is about to clear off. The relation of this is important. And if you have a STEMI intervention in which you have just opened an artery without having a myocardial blush, you will still have excessive acute and long-term mortality. Now, this is the body of my lecture, improving outcomes. So how do you improve outcomes? I'm going to share with you 20 critical concepts, half a minute, 1 minute each, and how exactly do they relate to saving lives. These are probably some of the most practical lessons I have learned. I have tried to incorporate both aspects equally of improving the process and the procedure, and also I'll finish my talk by trying to relate it to India and specifically to Mumbai. So this is concept number 1. And the concept number 1 is, how exactly did this start? This is my own work. I'll take just 1 minute to share with you. This is the Sincere database, the single experience, community experience registry, what I have been doing for the last 8 years in Miami. I have always used this as a dictum, as a slide. You'll understand the relevance of this, and I quote Mahatma Gandhi here: in matters of conscience, the opinion of the majority does not count. I used to have a burgeoning elective PCI practice, which I relinquished just following probably what I think is the finest and indication of PCI. It has definitely not been easy. This is the more recent data, 791 short door-to-balloon interventions. Again, this is not primary PCI. This is short door-to-balloon interventions. 71% of these are off hours. And if you break it down, 67% are done between 1 and 5 in the morning. And even in the United States, we have a lot of issues about it. Because these are a lot of emergency procedures, you're taking care of a lot of indigent patients, and almost 42% of these patients have no insurance. So, in the matters of conscience, opinion of the majority does not count. You will love the procedure enough that night after night, you'll wake up between 1 and 5 in the morning and take care of these patients and not get paid for it. Yet there is a lot of joy in saving these lives. Which brings you, how exactly do you reduce these door-to-balloon times? What is the methodology? What can I teach you? I would not come and talk to this august audience in Bombay and teach you something which I have not practiced. So here I quote Lord Buddha: you cannot travel on the path unless you become the path itself. So how exactly did I become a path? This is our home in Miami. This is the first hospital where I do STEMI interventions, 1 week at a time, on call, 281 nights on call, averaging each year. This is the second hospital, third hospital, fourth hospital, fifth hospital, sixth hospital, night after night after night. You have to maintain and understand the logistics, exactly like how it was coming here today. It could be rain, it could be all sorts of weather problems, it could be traffic, you could be in the middle of things. How do you do it? This is how you do it. I know exactly how far the first hospital is. This is how far, how long it takes to drive. I even know which car to take. This is the second hospital, third hospital, fourth hospital, fifth hospital, sixth hospital. And this has been going on night after night for the last 8 years, and there are lessons to be learned which we'll share with you. You start wondering, how do you maintain a lifestyle like this? And should there be dedicated people who should be doing it? Very relevant question. It's going to come to you sooner or later in Mumbai. I don't know the answer. I tend to believe you probably need. Why? Because this is what happens on a day-to-day basis. You'll have to sacrifice your lifestyle. There are logistical hurdles, various other challenges. This is how my car is parked ready to go. This is all I have inside the car is scrubs. This is how I sleep in the night ready to go. This is how the car is parked outside the cath lab. There are all sorts of notices. I'm always communicating. This is 2 STEMIs together. Last week I ended up taking care of 3 patients with cardiac arrest. That has been a first. It's not difficult once you're able to get the logistics right. This has been personally a little difficult, a little ankle injury working through with this. This is spending New Year's Eve. We thought we were going somewhere else, ended up in the cath lab. This is 37 traffic tickets and violations, and this is quite all right. It is this which is a challenge. Have survived several of these too. So on the basis of this, I can tell you that where each moment counts and you need speed and skills, you probably will need a time that this may emerge as a specialty. Let's learn some other lessons. Why is it so confusing? If you imagine if one of us had a heart attack here, how exactly do you take care of a patient? What exactly STEMI interventions? What are the challenges? How do you improve outcomes? The first thing is you have to divide STEMI into a process and a procedure. This is the process how a patient will reach a hospital. You have to get the patient to the right hospital in the hands of the right physician, and then the procedure is done. So whenever you're trying to understand STEMI interventions, this is what I request to you. Break it into this process and the procedure and try to work on both. This is again my work. I have created what I call the 10 commandments of the procedure. Most of it has to do with identifying the culprit lesion, managing the thrombus, achieving all the endpoints of a successful STEMI, which is relief of chest pain, TIMI 3 flow, myocardial perfusion grade, and relief of chest pain, and ST segment resolution. There are some other components of it. Then on the left-hand side is the process. How do you improve the process? We'll talk about that in more detail. It has to be standardized. It has to be almost the same thing you do night after night if you have to save precious minutes. This is how I do as an example. 15 minutes, let's start the car. So this is exactly what I do in most STEMI interventions each day. You give xylocaine anesthesia. You achieve access, very critical to have a clean access. You always perform angiography also of the non-culprit lesion also. Guiding catheters, 6 French catheters are enough. Hydrophilic works fine. Always aspiration, stenting, bare metal drug eluting, we'll talk in a moment. Nitroprusside, I think, to improve the myocardial perfusion grade, and I think it is essential to perform a left ventricular function. So fast again, here is it. Let's start. 15 minutes, that is what it should take you. An excellent, important access, mid-artery, clean access. Once the access is not there, you are in trouble. Get the pictures of the non-coronary artery, 6 French guiding catheter, hydrophilic wire, always aspiration, stenting, obtain, improve the myocardial perfusion with nitroprusside, and perform left ventriculography. Same thing, case after case. Let's go further into thrombus. I talked about perform aspiration thrombectomy or other thrombectomy. Why is it critical? This is the patient with the myocardial infarction. I have always emphasized that start with the fact that there will be thrombus, whether it is angiographically apparent or not. There always has to be. That is the pathophysiology. When you have thrombus, the initial thrombus, the very early presentation is a very red friable thrombus, which as the time frame increases becomes more and more dense and thrombotic. It is the dense thrombotic thrombus, and if you look at it, the management is somewhat difficult. It is difficult because it is much harder to take care of this dense thrombus than the fresh, friable, early thrombus. This is why taking care of patients who present early is so much easier than patients who come late. In addition, the patients who are coming late have already started going into pre-shock and cardiogenic shock. It becomes harder. Also, once the thrombus is more dense and organized, simple aspiration catheters don't work, and overall your task is difficult. Why am I emphasizing that? Majority of my patients are these easy cases. Majority of your cases are these difficult cases, which is why for you to go from this step onto this step, you need to improve the system so that patients are able to come to you early. Let's try to understand more about selective thrombus management. Let's try to have a strategy how you're able to identify thrombus, and based on the thrombus, based on the degree of thrombus, based on the thrombus grade, have a selective strategy. This is some of my more innovative work in it. This is how it starts. This is what I do. First of all, in the first cine angiogram, I'm trying to identify the thrombus grade. If you take a look, thrombus is graded from 0 to grade 5, and if you take a look at it, these are the examples of thrombus. And without going into the details of these 15 pictures, all it is showing is that you have virtually no thrombus to heavy grade thrombus with totally occluded, large thrombotically occluded vessels. Based on this, low grade thrombus you could probably direct stent. Anything more than that you probably need to aspirate. The dense thrombotic ones are the ones which really need more mechanical devices like the angiojet. These are some technical tips. I'll discuss these with my lecture tomorrow, so I'll pass this. But I think it is important to maintain, you will have thrombus, identify the thrombus grade, based on that have a strategy. Let's move on to the next concept. These to me are the 4 biggest questions which come in the care of a STEMI patient. The 4 controversies. I do a large meeting each year on STEMI, and these are the 4 questions which we discussed. I hope I have anticipated your questions, your thoughts correctly. These to me are the 4 questions. Here we go. This is what I call the Mehta 4x4 matrix. This is the first question, 4 situations where I use balloons. As I told you, I don't think it is a good idea to use balloons. However, where would I use it? I don't know where the wire is. You put in a small balloon, you get a little better idea. That is one of the places. In patients who have very severe ischemia, they are having such extreme severe, so you want to quickly put in a balloon, get some antegrade flow going, then you proceed with thrombectomy. In patients who have severe calcified plaques, I think it may help because none of the aspiration or thrombectomy catheters will pass. What is the 89-minute dilemma? Often what happens is in the United States, getting patients done in 90 minutes is so critical. When often you're handed a patient which is so late, you quickly put in a balloon, it's basically almost cheating. Beyond that, I think using balloons is a very bad idea. Try not to use them. Use thrombectomy, you'll be fine. Next questions. Bare metal stent or drug-eluting stents? Always a big debate. These are the 4 cases where I use drug-eluting stents. Long lesions, small vessels, proximal LAD, and diabetic patients. Beyond that, I think most patients can be done with the bare metal stent. 4 situations where I use 2B3 agents. What are those? Large thrombus burden, residual thrombus, a side branch involved with thrombus, and a result which is simply not good. Finally, this is probably the most important. We talk about door to balloon time, how critical it is. These are the 4 cases I shut off the clock. I don't need to look at it. Which are these patients? Patients with shock. Patients with any complication. You have a complication, you're not going to be worrying about time. It is more important to save a patient's life. You don't have a good access, or you need to change an access. You've gone through the groin, now you're going through the radial artery, right radial, left radial. These are not cases for you to worry. And again, sometimes you don't have adequate staff. You're working with one technician, so these are not the cases to rush through and jeopardize the patient's life. Concept number 9. This is the funny one, but it has an important message. A STEMI intervention, what I do night after night, is a blind date. What do I mean with that? Let me show you what a blind date, like trying to set up with a girl on the internet, a blind date. You know, I tell my wife, oh, I've become so good at it, don't worry, it takes me 15-20 minutes to do a STEMI intervention, driving back and forth, I'll be back in an hour. Really? This is what a blind date is. Here is a 400 patient, really? You'll do this in 15 minutes? Oh, I'm so good at getting access. It takes me 15 minutes to get access. Really? This patient has 11 stents in the iliofemoral region. And what about this commonest region? So this is funny, but this is probably one of the best lessons I can ever teach you. For some of you who are doing STEMI interventions, for some of you who have busy practices, for some of you who have to do many other things, and for most of us who are sleeping, the best lesson I can tell you, if you want to save lives, save precious time, if I can go back to that slide, is exactly here. This is the message here. The only event that you control in a STEMI intervention is how quickly you can abandon what you're doing and rush off to do a STEMI intervention. That's how you're able to make a difference. So a funny statement, but an important message with that. What about improving the process? What we talk about is a lot of pre-hospital work. We are able to do a lot of early activation of the patients. We are able to give the patient several early medications. This is what early activation does. You're able to activate in the ambulance. That I think makes one of the biggest differences. It also makes huge amount of differences in trying to either put technology in the ambulance or train the people so they are able to do a pre-hospital alert. Basically what you're trying to do, you don't wait for the patient to reach the hospital, you're able to diagnose STEMI way before that. The next concept, early pharmacotherapy. Often in the United States, that's not possible. You can easily do it in your country. This is the basis of this is some of the work I do internationally. In 18 countries, I am helping them with their STEMI systems. Almost none of them is able to do any pre-hospital thing. You're easily able to do this. This is as an example what I'm doing in Puerto Rico. What are the big things we are able to do? 100% pre-alert, 100% initiating pharmacotherapy, and what we try to do is bypass the emergency room. The concept is that the patient goes straight from wherever he's coming. Now, you will think that, look, in India, you're not having ambulances. Most of the patients come themselves. That's something a little different, which hopefully will change. But this is how the concept is, that the patient is brought by the ambulance, he bypasses the casualty and the emergency and goes straight to the cardiac cath lab. There is no reason to be wasting time. We are saving a lot of time in these areas. We also realize that people who take care of these patients are very different. And it is when the patient is handed from one to the other team, this is where mistakes happen. So some of the areas how we are able to eliminate mistakes. This concept is a little more difficult. There are several people who are involved in the care of a patient having an acute myocardial infarction, the interventional cardiologist, the casualty physician, and the person who's transporting the patient. The concept is we are trying to let this process start immediately. If you're going to track down the interventional cardiologist, it is too late. We empower the people who are taking care of the patients and they start the process. Let's try to put it all together, what I have taught you. It's all going to be lots of people working together. This is how it happens. This is how a patient has a heart attack. What happens most of the time? There is no access to ambulances. He either drives himself or has some relative who drives himself. They go to the hospital. Hopefully somebody will see him early. They'll do an EKG. They'll diagnose an acute MI. They'll take him to the cath lab and somebody opens his artery and you realize this is amazing work. What if I told you this will not work? What if I told you this will not work in the majority, this will not work efficiently, and this is definitely not the way to do a door-to-balloon STEMI intervention? There are many things wrong. Number one, patient gets chest pain, it is important for them to go in an ambulance. I understand what your doubt is. You are not having a well-cared system here. We'll talk about that in the next 2 or 3 slides. In the ambulance, the STEMI is diagnosed, the EKG is transmitted, he bypasses the hospital, goes straight on the cath lab. So in the first model, this is wrong, this is wrong, this is wrong, this is wrong, and hopefully I have taught you some of the ways how the system can be improved. Next concept. You're talking about a hospital. What if I told you, let's try to improve not only hospitals, but the entire South Bombay? Then I said, look, hold on, why South Bombay? Maybe the whole of Bombay. What if it is the whole of the country? You have to have a system which is based on providing care for the entire population. And this is some of the work I've been doing in Puerto Rico. An entire nation, an entire island, 4.2 million people, small by India standards, but every hospital has developed a standard, a system of care. This is how we do it. You distribute, you try to figure out the logistics around every hospital, and based on that, you are able to do care specified for these patients. Patients who live close by get primary PCI, patients who are a little further get pharmaco-invasive treatment. The same way I have created, this is the world's biggest STEMI hospital, the Fuwai Hospital in Beijing. Exactly the same methodology and principles. You have to be pragmatic. One of the best works in this is a trial known as a transfer AMI. What is it? A patient in the outskirts of Mumbai has an MI, he gets a lytic therapy, then he's transferred and he gets a PCI. Basically, a pharmaco-invasive, it is probably going to be one of the better ways to treat in a country like India. I know there is a debate happening tomorrow between Dr. Pelajani and I think Dr. Sharma, so I'm not going to say anything further. But let me tell you what this means. In a poor country, this is the financial impact. He gets lytic therapy, he sells his livelihood, then he goes for PCI and sells his house. This will not happen. There has to be a balance, and this is what I have proposed. I call it the Mehta model of the transfer AMI trial. I have broken the patients into 4 groups. A patient who's clinically stable but has no money, a patient who's clinically unstable and also has no money, a patient who's stable but can afford, and a patient who's unstable but can pay. What am I trying to tell you? That you don't have to blindly follow what has been done in the West. Everything is possible. Science is possible only if it is financially and fiscally responsible. Concept number 18, just 2 more minutes I should be done. Like politics, all STEMI programs are local. This is Dubai. I've been helping them over the last several years. What happens there is there are these 2 hospitals, but not enough staff, not enough doctors, so we combined the 2 programs together. Local understanding of the community. This is the Max Hospital in Delhi. How they've been able to skirt around some of the local political issues and able to transfer. So some of this is all local. This, of course, is Beijing. And this is, of course, at the moment, a lot of the way I've been able to do designing population-based STEMI programs. Second last concept, we've talked about everything else. Why not talk about Bombay? How do you provide care to these patients in Bombay? This is one of the strategies. This is the pure PCI model. Here there are 10 hospitals, there are probably more, but there are 10 major hospitals which do STEMI. I think they'll do a fantastic job. You transfer to these hospitals early. But then how many patients can really be taken care of? So this is the same patients, same PCI centers. You know, let's add every other center. These are, of course, some of the challenges I kind of created. What happens there? Please understand, I come to India so often, I go to so many hospitals. I do understand some of these things which happen. Number 4 is the one which bothers me the most. What I call it a chalta hai attitude. Everything is okay, you know, it'll be okay. Not okay. When it is your loved one, when it is your father, unfortunately in India it could be your son. It is not. Everything is not right, chalta hai, it has to be changed. So these are some of the modalities. This is the same thing. What I have done is now I have added every small nursing home where a patient can get lytic, and this becomes your strategy number 2. This is going to be debated tomorrow. These are the other ways how some of this can be done, but believe me, not only will you do it in due time, I think you'll do a wonderful job. This is a much larger message. How would you do a PCI for the entire country? This is some of the things which happen, and this bothers me. This goes to my initial theme of, in matters of conscience, opinion of the majority does not count. You know, I go to Delhi, and this is the sign of this amazing country. Right here from Pune, you know, here the Tatas own the Range Rover. Great success story. This is the Hyderabad airport, voted number 3 in the world. This is the expressway outside Gurgaon. This is the IT Infosys Center, the New Delhi Metro, third class hospital care and poor STEMI care. It is just not acceptable. How can we as a nation be proud of so many incredible things but not be able to save the lives of our precious one? It takes me, as I told you, the interventional cardiologist, 15-20 minutes to save a life. This could be a life of your loved one. All we have to do is to create a system which is efficient. I think this will happen in India in 4 steps. I call it level 1, level 2, level 3, level 4. Level 1 will take a long time. I think it will take several years. You need to have available, everybody should get at least a thrombolytic agent. Level 2 would be developing of a reliable ambulance system. Level 3, which is happening in some cities already, is a pharmacoinvasive, and I think the eventual goal is everybody should get primary PCI. This is my last slide. Probably the most important message. And this is what the message is. The reason some of the progress is not occurring in AMI, the reason people are dying, the reason 40-year-olds die in India is because we think it is the job of a cardiologist. I think it's totally wrong. I truly believe that STEMI care is basically a national, it's a public health issue. It's a public health issue in which many people are involved. There is, of course, the family physician, so many of you here, who has to understand what is available, where a patient can go, where he can get this treatment. There is, of course, the cardiologist to whom the patient will come back. The interventional cardiologist just needs to understand how to take care of the procedure. The hospital has to understand if you take care of a patient who's having an AMI, you have to provide all sorts of services, including transportation, emergency. I think the media is a part which is still not active in India. Fortunately, it's almost like with Anna Hazare, they have to get behind this initiative, and you'll probably get it right, in which we have to educate the patient. I think the patient is a critical part, because if the patient does not take care of himself, don't expect a doctor to. And finally, if you're somebody who's a politician or somebody else who dictates our life, you might as well allocate resources, because the next patient could be you or your loved one. I apologize. I know I have gone a little beyond my topic. I hope some of these messages have been useful to you. This is a meeting which I do, a little advertisement I'm doing for myself, a large Lumen meeting, consistent with my thought that the relevance of my work is most in the Asia-Pacific rim. I have moved the meeting to Dubai, hopefully to Bombay one of these days. Thank you so much once again for inviting me, and it's a pleasure to be here.